Welcome to AETCM, the emergency medicine channel. So in this part 3 of cardiovascular emergency, today we are going to discuss about the cardiac failure. So content of our presentation, definition, classification and in etiology, pathophysiology, clinical features, differential diagnosis of cardiac failure and then finally management of how we have to tackle over that case in the pre-hospital scenario. So first one is a definition. So heart failure is a syndrome that is most important, occurs when the heart is unable to empty its chamber. So unable to empty, unable to eject out the blood from its chamber. Here we told two reasons: unable to pump powerfully enough or fast enough. So otherwise, in other term, inadequate contractility or in the heart rate related an issue. So to understand that concept, if you remember the cardiac output formula, easily it will be understandable. So cardiac output is equal to heart rate into stroke volume, right? So stroke volume in the sense it will depends upon the preload and then after load, then it depends upon the contractility of the heart. So if any problem in this part, that will directly affect the cardiac output. There means if any problem in the heart rate, if it is a bradycardia, otherwise asystole, that will affect the cardiac output. If any problem in the stroke volume, means if increased preload or increased afterload, or if any problem in the contractility, means directly that will put hand on the cardiac output, thereby it will reduce that chamber content will reduce, the ejection content will reduce, that will cause the heart failure or cardiac failure. So it will ultimately result into the blood backups into the systemic circuit, pulmonary circuit or both. So the if the unable to receive means that blood stagnant will everywhere else. So in pulmonary circulation also it will stagnant, systemic circulation also it will stagnant. So classification wise, by definition, we are classifying into systolic heart failure, diastolic heart failure. Systolic means something is affecting the contractility function. Systolic means contraction. So diastolic means some causes is affecting the relaxation of the heart. That is systolic and diastolic heart failure. Second is a high output failure, low output failure based on the cardiac output. High output failure means the normal heart fails to maintain the normal or increased output in condition like anemia, hyperthyroidism, pregnancy. So we'll take anemia. So like last presentation, what we'll do, there is an imbalance between the demand and supply. That is the same concept. If your cell want 100 molecules means here, but your heart is supplying only 40 molecules. So your demand is increased, but your supply is less. So here, how the body will tackle over this condition, how the body will compensate this condition. So again, that's cardiac output formula. If you want to handle this condition means that should be a heart rate in stroke volume, right? So if you want to compensate that condition, so if the heart rate is increased means, so the output will increase, thereby it can try to compensate the supply, there it can try to compensate the demand. So that is the condition. So if any disruption happening, otherwise if the compensatory mechanism get fails means that will cause the high output failure. Low output failure means heart fails to generate the adequate output. Same thing only, adequate output means like condition like cardiomyopathy, valvular heart disease, cardiac tamponade, tachycardia, that is the bradycardia, that is the condition will cause the low output failure. The output get reduced. So third thing, based on the side, right side heart failure, left side heart failure, and then if both is there, the both clinical feature is there means that is the congestive cardiac failure. Then next is based on the American Heart Association, they have a 4 stages like stage A, stage B, C and D. Stage A, what is means at a risk of heart failure but without any structural heart disease. Structural heart disease in the sense any cardiomyopathy, those are the dilated cardiomyopathy, those are the things. So stage B in the sense structural heart disease but without any signs and symptoms of heart failure. Stage C in the sense structural heart disease with prior or current heart failure. Stage D in the sense refractory heart failure that needs some special interventions. So further intervention that needed. It is based on the American Heart Association. And then next coming into the what might be the causes. So here we are categorizing based on the ejection fraction. So ejection fraction means amount of blood that is ejected from the left ventricle in a each beat, otherwise in a each contraction. So normal it is about 50 to 70%, right? Ejection fraction, normal ejection fraction. So first one is a reduced ejection fraction. Like ejection fraction is less than 40. Like condition like coronary artery disease, chronic pressure overload, chronic volume overload, non-ischemic dilated cardiomyopathy. If it is a ejection fraction is 40 to 50%, condition like a hypertrophic cardiomyopathy, hypertensive heart disease, restrictive cardiomyopathy, fibrosis, and right side heart disease like carpulmonale, pulmonary vascular disorder. What is meant by carpulmonale? Carpulmonale in the sense here cardiac failure happening because of the pulmonary pathology. Because of the pulmonary pathology, heart failure is happening. Means think we'll take one example of pulmonary hypertension. Here what will happen? So the pulmonary hypertension cases, the afterload will increase. So thereby, if your right ventricle want to eject blood means it have to take more effort, because the afterload will increase means, so it have to take more effort to pump the blood. If it is doing for more time means the muscle get fatigue, and then ultimately it goes into the cardiac failure. So carpulmonale means heart failure happens because of the pulmonary pathology. Next condition is an high output states like thyrotoxicosis, nutritional beriberi, and then anemia. So next coming into one pathophysiology. So if we understand the pathophysiology, easily we can write about, otherwise easily we can identify the clinical features, and then easily we can go for the management. So first, right heart failure. So what is the function of the right heart? So it will receive blood from the right atrium, and then it will get the blood from the right atrium, and then it will eject that blood into the pulmonary artery. That is the function of the right atrium. So if it get the function of the right atrium get fails means it unable to receive from the right atrium, it unable to pump out the blood to the pulmonary vasculature. That will thing will happen. So because of the right ventricle failure, the cardiac output will reduce. Why? So unable to pump out the blood into the pulmonary vasculature. So if it is pump out means then only the blood can reach out the lung and then get oxygenation, then only it can reach out the left side. So because of the failure, the pump, the drainage will reduce, so input will reduce, so the output also get reducing. So output reduce means that will cause the perfusion, decreased perfusion to the tissues. Tissues in the sense that includes kidney also. So if kidney getting reduced perfusion means what it will do? So it will activate the compensatory mechanism, that is the renin angiotensin aldosterone system. So the system is like this. So angiotensinogen in the presence of renin you will get a angiotensin 1, and then in the presence of angiotensin converting enzyme you will get a angiotensin 2. This angiotensin 2 is a potent vascular constrictor, that is a vessel constrictor. Okay, then it will convert into angiotensin 3, then it will metabolize into aldosterone. So aldosterone what will do means it will retain the sodium and then water. Retention of sodium and water, that is the main compensatory mechanism. So this system get activated. So two major things. So the angiotensin 2, that is a potent vasoconstrictor, aldosterone that will back up, that will retain the sodium and water. So by this what will happen? So because of the vasoconstriction, the peripheral vascular resistance will increase. Mean the same time because of the aldosterone, because backup of the fluid and then sodium, again the systemic fluid level will increase. So that is the thing, sodium water retention, backup of fluid into the systemic circulation. So up to this is happening because of the compensatory mechanism. So what you are thinking about this compensatory mechanism? Already the heart in somewhat stress. Again, if it is increasing the preload, again the vascular resistance is increasing. Mean the same time the load, volume load also increasing means So the compensatory mechanism, compensatory mechanism, uh, either it want to act like a hero, but here it is act like a opposite character, negative character. So it will increase the workload of the heart. So that is because of the compensatory mechanism. Second thing, because of the venous congestion, it will cause the edema, and then it will increase the jugular venous distance and cerebral edema. So two function we told. First one, it have to receive the blood and then it have to pump out. Okay, so first, because of the reduced cardiac output, that some other compensatory mechanism happen, renin angiotensin. Second thing, because of the venous congestion, that is causing the edema and then jugular venous distance. So the same thing happening in the left ventricle. So left ventricle means decreased cardiac output. So the same concept, until this sodium and then water retention happening. So because of that, so there we told systemic vascular overload, fluid overload. Here the fluid backup in the pulmonary veins. Okay, then it leads to the high pressure in the pulmonary capillaries. So if the pressure inside the capillary increase means, that will automatically leads to the fluid escape from the pulmonary vasculates into the interstitial area and into the alveoli. So that the condition is called the pulmonary edema. So that is pulmonary edema, right? So fluid inside the pulmonary capillaries or pulmonary vasculature, that is escaped and then that reach out the interstitial area or into the alveoli, that is pulmonary edema. So because of pulmonary edema, what will happen, that your air exchange get impaired. So air exchange get impaired means you will get a hypoxia. Hypoxia means that leads to the cyanosis, and then further condition it will progress into the next condition, and then it will cause the pulmonary edema, and then orthopnea, pink frothy sputum, paroxysmal nocturnal dyspnea. So this will happen because of the left ventricular failure. So clinical features wise, because of the left ventricular failure, these are the signs like objective data. So the person will be in a restlessness, anxiety, respiratory heart rate above the normal for the age, pulses or alterness. This thing mainly will get in the intra-arterial. So if we kept the intra-arterial line, like for BP measurements, here you will see the pulses alterness, and then crackles. While auscultation, you can hear the crackles, and then third heart sound. Because of the dyspnea, you will get the retraction, accessory muscle usage, tripod position, sweating, inability to speak in a complete sentence. That is also because of the dyspnea. So in the case of right ventricular failure, there will be a congestion in the vein system. So there will be a weight gain, dependent edema, ascites, anosarca, this is jugular venous distension, hepatomegaly, splenomegaly will be there. So in left ventricular symptoms, that is a subjective data wise, fatigue, difficult in breathing, orthopnea, paroxysmal nocturnal dyspnea. Right ventricular failure symptoms wise, fatigue, nausea, loss of appetite, right or left upper abdominal quadrant pain. And then coming into differential diagnosis. In cardiovascular system, we told cardiac tamponade is the cardiogenic, non-cardiogenic, high altitude pulmonary edema, myocardial ischemia and infarction. And respiratory causes wise, ARDS and COPD, chronic bronchitis, asthma, and then your pneumonia, pneumothorax, respiratory failure. Other causes like anaphylaxis, aspiration, toxic exposure. So these are the clinical condition also mimic like a heart failure. So these are the symptom condition also mimic the same features of heart failure. So assessment wise, general impression first, while seeing the person itself, we can, if the person in tripod position, because of the respiratory, the dyspnea, distress means the person will be in a tripod position. Then shortness of breath, that will limit the speech. And then breathing part, if you're going means, there you can see the, because of the increased respiratory distress, the person will use the accessory muscle, pursed lips, tripod position, those are the things, so that you can see. And then respiratory rate is often rapid. While auscultation, you can hear the crackles. Sometimes it may accompany with a V sound also. Circulation part, you can assess the peripheral pulses and then skin changes like CTC of the skin, condition, temperature, color of the skin. There you can go. There you can see the pale and feel cool cyanosis also. And then you can see the third heart sound, we can auscultate. Apical pulse, that may be displaced as enlargement of the left ventricle. In the case of cardiomyopathy or a cardiac tamponade cases, that might be disappear, otherwise that might be displaced. And then hypotension also we can see. And then again, assessment wise, if the person is complaining shortness of breath means, the two major thing we have to ask, either that is a gradual onset or sudden onset, that you have to ask. Second thing is that either that is happening, the dyspnea occurs because of any exertion, because of any physical activity, or in rest, that we have to ask. So again, the third important thing, the again the person is complaining dyspnea means either that is disturbing his or her sleep or not, that is indicating the paroxysmal nocturnal dyspnea. And then we have to assess the signs and symptom of heart failure, restlessness, anxiety, unexplained confusion, and then concentration means that is indicating the hypoxia to the cerebri. And then again, if the person had a history of any nausea, loss of appetite means that is indicating like a congestion of the liver and other abdominal organs like your portal circulation, venous congestion. So management goals wise, three management only. First concept is that we have to decrease the respiratory distress and then decrease the work of breathing. Second thing is we have to decrease the workload of the heart. Third one is we have to maintain the adequate oxygenation and perfusion. So what is the management step we have to follow means, first step, reassurance the person, reassurance the patient, because even with the anxiety itself, the heart rate will increase, again the BP will increase because of the catecholamine action, no, that everything will increase. So again it will put the person in the stress, and then the person in the heart in the stress, respiratory function in the stress. So reassurance the person, tell them we are here, don't worry, we'll manage this condition simply, and then we are going to transfer this to this hospital, so you will get better easily, like that you have to reassure the person. And then limit the person activity, physical activity, try to carry. So if you want to the person in the first floor means you can carry your stretcher or whichever thing. So stretcher is appropriate thing, no, so you can carry your stretcher, from there you can shift the person, so thereby we can limit the person activity. Position the person, whichever comfortable position for the person, that we can provide. Cardiac monitor and then 12 lead ECG, we can attach supplemental oxygen based on the person's respiratory distress, even with the nasal cannula up to the NIV we can go for. And then non-invasive positive pressure ventilation, that is one of the main and then successive management in the cardiac failure and then respiratory distress. So these that NIV have some set of advantages that will improve the oxygenation and perfusion by reducing the work of breathing. It will maintain the alveolar inflation. How? So it have a P pressure, no, positive end expiratory pressure. Thereby that end expiratory pressure that will prevent the alveolar collapse, and then it will improve the pulmonary compliance. It will slows the respiratory rate, thereby it will decreasing the work of breathing, heart rate, and systolic blood pressure. It will decrease systolic blood pressure means while the time of this, here we are giving the positive pressure ventilation, so the intrathoracic pressure will increase, thereby the BP will decrease. So it will facilitate the delivery of bronchodilators. If you attach with an NIV means you can connect with an your that port, that nebulization mask, then you can give the bronchodilator also. It will reduce the preload, afterload, and thereby it will increase the cardiac output. So NIV should not be in some other cases. If the person is cardiac arrest or respiratory arrest or altered mental status, if you are documenting hypotension, that is systolic blood pressure less than 90 mmHg, or the person in risk of aspiration, or in the compromised airway, or in the pneumothorax cases, there we should not use the NIV, and that is the absolute contraindication. And then after inventing the NIV, before and after the inventing NIV, we have to monitor the respiratory rate and then wave. If in your crew, if you have a waveform capnography means, that we can use, otherwise you can go with an pulse oximetry. Before and after you have to auscultate the breath sounds. So we have to establish the IV axis. Here the already the heart in congestion, so you should not add more and more fluid. We should not administer more and more fluid. Here you have to administer more judicial way. Until unless if it is necessary, you can go with an 30 ml per hour. Otherwise, based on your medical director guidance, you can go for the fluid infusion, fluid administration. So pharmacological therapy ways, here we can go with an sublingual nitroglycerin and then furosemide. So nitroglycerin is a vasodilator, furosemide is a diuretic. So the dose, everything depend upon the person's condition. So based on the condition, we can give the sublingual nitroglycerin. Usual dose, we are in ACS condition, will give the 0.4 mg. No? So here, based on the person condition, the dose range will vary. So surgical ways, ventricular assisted device, intra-aortic balloon pump IABP, and then ventricular reduction surgery, heart transplant. That is the definitive treatment that will carried out in the inside the hospital. So outside the hospital, in pre-hospital, mainly we are concerning the three things alone. We have to reduce the work of breathing, heart function, reduce the workload of the heart. We have to maintain the adequate oxygenation. So in coming into one that ventricular assisted device, some of the clinical importance, otherwise some of the practical importance you have to know. So first we will see what is meant by ventricular assisted device. So ventricular assisted device means, so the name itself that is explaining ventricular assisted device. So it will assisting the ventricular function. So based on the failure they will place. So if it is the left ventricular need assist means they will place the LVAD, left ventricular assisted device. Right ventricular corresponding area that will place. If both ventricle need means will place the biventricular assisted device. So parts wise, here you have a three parts. So first one is a pump part, second one is a tubing part, third one is a power source. Clear? So blood pump and then tubing part and then external power source. So we are categorizing based on the four categories. We are categorizing the ventricular assisted device based on according to the type of blood flow. Either it is a continuous or pulsative. Blood flow in the sense continuous means throughout the cardiac cycle it will eject the blood, it will pump out the blood. Pulsative means like a normal heart. In systolic it will eject, in diastolic it will relax. In systolic likewise pulsative. The length of time, either we are placing that VAD for short time or intermediate or long time, the length of time for what purpose. And then source of driving forces, either it is operating with an electric source, otherwise pneumatic source. Device location, either we are placing internal or external. So some of the practical aspects, like we told, the continuous flow of VAD node, no, that will deliver the flow throughout the cardiac cycle. So that will deliver blood flow throughout the cardiac cycle. In this cases, palpating the pulse and then obtaining the blood pressure through one sphygmomanometer and then taking a pulse oximetry, that is quite bit difficult, because here we told there will be a continuous flow, there won't be a relaxation, there won't be a contraction. So the pulse is happening because of the systolic and then diastolic. There will be a wave, systolic, because of a systolic and diastolic function of the heart, there will be a wave form of pulse. Then only there only the pulse is creating. Here there is no systolic, there is no diastolic. It is like a steep fast flow. No, so here palpating pulse and then doing an sphygmomanometer, that is a little bit difficult. Otherwise we won't get, that is a very weak and then absent pulse will get. Second thing, every ventricular assisted device, people will have a ventricular assisted device coordinator, the concerning physician will be there. So if you are handling one person means, try to contact that person and then to get history regarding that person. And then more specifically in the case of cardiac arrest, uh, if the person with a ventricular assisted device, if the person have a cardiac arrest means, that is a most worseable situation, because there will be a dilemma whether we can do a compression or not in that VAD device persons. In our Nancy Caroline, they are mentioning like a chest compression are not usually performed because of the possibility of a pump dislodgement. Some of the people they are telling like life is most important compared with a pump, so we can do chest compression. Likewise, some people are telling like it will cause the pump dislodgement, thereby it will land up in some other complication. So always there will be a dilemma in these cases. So better to contact the online medical director and then ventricular assisted device coordinator. This was the some two important practical aspect in the ventricular assisted device. So do your best. Shalom.